Hi again, everyone. Sorry about this technical issue that I had in my office. I mean, technology will always be a mystery for me. I'm using the same Wi-Fi as Dr. Razi in the same building. So again, apologies about the delay in the technical issues. And the last slide that I was going on with the previous presentation was mainly a summary and a take-home messages that goes over what we discussed during the talk, and it doesn't have any extra information, but I'm happy to answer any questions at the end of the session, obviously. So now I'll be talking about pre-kidney transplant evaluation of the recipient. I know that Dr. Martina McGrath talked about the donor, so no disclosure. I will start first saying that the pre-transplant evaluation is a very important step before transplant and also one of the most challenging tasks in the process. We are asked to make a decision whether a patient is a candidate or not for kidney transplantation, and this decision is based on prediction. We will be using medical history, physical exam. We have always access to different testing, but at the end of the process, we should be able to answer the question whether the patient is a good candidate for a transplant or not. And for that, we need to ask ourselves the big questions, which are why this patient should get a kidney transplant, which patient should get a kidney transplant, and when is the best time for a candidate to get a kidney transplant. Because at the end of the day, not all patients are suitable candidates for transplantation. So first, let's answer the question why we choose to give a kidney to transplant a patient with a kidney. Many studies have showed that there is a survival benefit of transplant versus remaining on the waiting list or remaining on dialysis. And this paper published in the AGT in 2010 looked at the benefit of kidney transplant versus remaining on the waiting list in different categories of potential recipients. They looked at patients waiting for a kidney transplant alone, meaning that didn't have any previous kidney transplant or any other solid organ transplant. They looked also at potential recipient waiting for a kidney after they received a lung transplant, after they received a heart, and after they received a liver transplant. And what we can see here is that the conclusion is there is an obvious significant survival benefit in patients who receive the organ when compared to the solid line representing the patient who remain on the waiting list. So this gives you the answer that yes, patient will have a higher survival rate after transplant compared when they remain on the waiting list. Then in this meta-analysis, not only the survival this meta-analysis showed not only the survival is getting better, but it's also the quality of life and the rate of admission for different kind of complication, specifically cardiovascular related complication. So as you can see on this slide, in this systematic review, they looked at the different ratio of cardiac event on the left side of the chart and hospitalization among transplant recipients compared to patients who remained on dialysis. And you can see that the diamonds represent the ratio of cardiac events and hospitalization between transplant patient and those who remained on dialysis, either it's hemodialysis or peritoneal dialysis. And the gray diamonds represent the unadjusted ratio, where the solid black diamonds represent the adjusted ratio. And you can see that there is a clear benefit in favor of the transplant in terms of any cardiac event, heart failure, myocardial infarction, or any cause of hospitalization, including infection. And they also looked at the quality of life reported by patients asked based on a questionnaire. And the vast majority of analysis, again, showed a significant favor for transplantation over hemodialysis when it comes to quality of life. So this gives you another answer on why we should transplant patient. The second question is, when is the right or best optimal timing for a kidney transplant? So multiple studies have shown that the earlier the referral for kidney transplant is made, the best are the outcomes. And this is a very well conducted study published again in AGT, where the authors analyzed data from 2,500 kidney pair. And what they looked is that each kidneys will from a same donor will go to two different recipients at the same time. Half of the recipient will be on a dialysis for more than 2 years, and half of the other recipient will be on dialysis on less than 6 years. And they compared those pairs. And as you can see, we can see a very clear, significant difference in graft survival at 5 and 10 years in favor of patients who were on dialysis for a shorter amount of time. So ESKD time has been shown to be the strongest modifiable risk factor for kidney transplant outcomes. And perhaps part of the advantage of the living donor versus cadaveric donor is explained by the waiting time, since most of the living donor recipient can receive their transplant pretty early on time. We also know that one of the strongest predictor of allograft and patient survival is quality of the donor allograft. So why should someone accept low quality kidney then for their patients? And kidney that are low quality are called marginal or extended criteria kidney, and they are generally speaking reserved for patients who can significantly wait longer on the waiting list and have again develop all these cardiovascular complication and other infection and require longer admission if they wait for a standard criteria kidney. And this is because the waiting time will be longer. So the question is, who should receive this what called extended criteria organs? So in this paper, the authors tried to answer this question. First, they showed that patients who are 65 years and plus have increased risk of not receiving transplant while on the waiting list. And here you can see the time on the waiting list while being active, mean that patient is willing to get an offer at any time, when compared to younger patient who will spend less time on the waiting list and will receive earlier offer. And so these patients, 65 years and above, would benefit from getting a marginal kidney. And they also looked at the question more in detail, and they used a sophisticated statistical technique to kind of estimate the life projected expectancy of patients to compare what would the life expectancy of these patients be if they receive an extended criteria kidney and they come off dialysis sooner versus waiting for longer. So the first set of bars, they looked first at the youngest set of patients between 18 and 39 years old, and they showed that they found that those patients will get out of dialysis sooner by getting a marginal kidney, but their life expectancy will be of 10 years. However, if they receive a living transplant or a normal criteria kidney, then their life expectancy will benefit better. However, if you look at the bars representing the older, like 55 and 65 group, if they wait 2 years on the waiting list and can get an extended criteria, their life expectancy will be a little over 5 years. But if those same patients within the 4 years get a standard criteria and wait longer, then their life expectancy is about the same. So that's why these extended criteria organs are usually dedicated to the patient who are 65 and plus, elderly patient who may wait longer on the waiting list, and they may develop more complication and with a poor survival rate sometimes. So after discussing when and why to get a kidney, let's talk about who to refer for kidney transplantation, or who are the best candidates and what are the criteria. So there are enough data that support the referring process, and the KDIGO had very clear recommendation for referring patients for kidney transplant. We know that also the Medicare requires referral based on these criteria, referring a patient to pre-transplant evaluation include all patients with chronic kidney disease with an eGFR less than 30 who are expected to reach end-stage kidney disease, and they should be educated about that, considered for kidney transplantation regardless of their socioeconomic status, sex, gender identity, or race and ethnicity, except for patients with specific condition that I'm listing here. So patient with multiple myeloma, light chain deposition disease, heavy chain deposition disease, they will not be referred, or they will not be candidate until they receive a curative treatment regimen and are in stable remission. And now with a new technology and the flow cytometry, we can also assess the patient to see if they reach a negative minimal residual disease of their multiple myeloma after treatment. Patients with decompensated cirrhosis are also not good candidate unless they are considered for a combined liver and kidney transplant. Patients with severe irreversible obstructive or restrictive lung disease can also be considered if they are getting a lung disease. Same thing with patients with severe heart failure, and patients with active malignancy obviously need to get a suitable treatment and be in stable remission before being considered. So the main rules for the recipient evaluation is not to harm the recipient, not to harm the donor, and not to harm the list. And when I say not to harm the list, means that we have obligations toward the list, and we need to make sure that we are assigning for the right patient the right organ, and we are not preventing some other patient more suitable for specific kidney and specific organ. So this is what I meant by that. So there are objective evaluation of the recipient to identify specific risk factors in each candidate that could either present an absolute contraindication, or that can mandate expertise and expert evaluation or specific management. So we need to assess patient for based on their medical history, surgical, social, psychological history. All patients can be considered for transplant regardless, obviously, of what I just said, socioeconomic, sex, gender, or race. We need to educate them about the risk and benefit of transplant. We need to discuss the donor options. We usually try to encourage the living donor option when it's available and possible. Patients most of the time don't think about it, so we need to discuss this option with them. We need also to go in detail over the immunosuppressive management, the complications related to that. And in a multidisciplinary meeting team, we usually discuss all the results of the testing and all the profile of the patient to come up with, again, the decision that will make the patient's life better, obviously. So what are the contraindications for kidney transplant? So there are absolute contraindications that are listed on the left side of the slide, including chronic illness with life expectancy less than 1 year. As we talked about, decompensated cirrhosis unless there is a liver kidney possibility, and controlled symptomatic cardiac disease unless there is also a possibility for heart and kidney, active malignancy. The relative contraindication, though, include the following: class 2 or 3 obesity. So we have a weight management clinic that help us manage this patient with a BMI above 35. Patient who has a history of glomerulonephritis, an autoimmune disease like lupus and lupus nephritis, need to be in complete remission and stable before being considered for transplantation to avoid risk of recurrence. Patient with frailty, with a physiologic reserve and potential perioperative complications and extended length of stay at the hospital needs to be optimized we can work on that with, again, the Frailty Clinic. A patient with severe peripheral artery disease, usually the transplant surgeon can assess the possibility to do the anastomosis and the availability of healthy arteries and veins, and then they can cooperate with the vascular surgery as needed. And patients who are in the active use of substance can receive appropriate treatment to achieve a minimum abstinence period of 6 months. So basically, our evaluation process will go as any other like general medicine evaluation, and goes by systems. And we will start here with the cardiovascular system. So we usually use a risk stratification approach. Obviously, we take the medical history of the patient. We plan on getting non-invasive coronary disease screen for the patient, especially taken into consideration patients who are not on dialysis yet and who would like to keep their residual kidney function. So we will be assessing, obviously, starting with an echo and going to like a stress test, medical stress test. Patients with severe heart failure will probably not be suitable for kidney alone, and we can refer them for a heart transplant and kidney transplant evaluation. And we will evaluate candidate as well for, as I said, the severity of the peripheral artery disease. What are the best tests that we use to screen for cardiovascular risk in our kidney transplant candidate population? So usually it's recommended, obviously, one would think that proceeding with a coronary angiography in patient with positive test will be the best approach. It was controversial because first, again, it's sometimes challenging to offer an angiography as a screening test for a patient with a residual kidney function on PD, stomach, and urine. So we are mostly using non-invasive testing like the echography, the scintigraphy, the dobutamine stress echography, although some of these patients have been shown, as in this study published in 2016, that some of these tests will not have a good specificity and a good sensitivity enough to detect a patient with real coronary stenosis, as we can see here. So the approach that we have at Brigham and Women's Hospital here is based on this algorithm, where we start with obviously a history, physical, low-risk patient who are young, no medical history, normal EKG and echocardiogram, will not need further workup. Whereas if we go to the echo and it shows some kind of reduced EF or some other abnormalities, then patients can be considered either intermediate risk, and then they can go to like a stress test, and our preference at Brigham and Women's Hospitals goes to the PET-CT stress test or the SPECT nuclear stress test. And patients who are high risk with history of prior coronary artery disease or unstable cardiac symptoms or cannot achieve an adequate stress testing, then they will go over the coronary angiography, and then they will see cardiology, and we can advise with our cardiology colleagues whether patient could be a suitable candidate or not. It is also very important for us to assess the functional status and the frailty of our patient. Usually what we do is we ask the patient to walk with us in the clinic. We obviously ask them about their daily basis activity and their walking capacity, climbing the stairs capacity. So there are a couple of tests that are used and they are clinic-ready tools that help assessing that. It remains pretty subjective because of different biases, including recall, overestimation, underestimation by the patient. But I would say that the 6-minute walk test is pretty good test because it takes, as the name indicates, 6 minutes and show independent predictor cardiovascular event-free survival in patients as shown in this study. And you can see that patients who are able to walk less than 300 meters are less likely to survive after 3 years. This is a test that is very helpful and very easy to do during clinic when is possible. In terms of nephrology evaluation, what we also do is obviously evaluate patients for their cause of the kidney disease, when they started dialysis, the etiology that led them to the dialysis, and the idea is to estimate the risk of recurrence of the disease after transplant. And here we have some numbers of risk of recurrence, with the highest risk associated with MPGN, FSGS, membranous nephropathy as well, and IgA. Some other cases, atypical HUS also has high risk of recurrence. Monoclonal immunoglobulin deposition disease needs to be also treated and achieve a complete remission and stable remission before considering patient for transplant. And usually for a patient with lupus nephritis, antiphospholipid syndrome, and ANCA-associated vasculitis, we will defer transplant until primary disease is completely quiescent. And this slide shows you the proportion of survival of the allograft in patient depending on their primary disease and also depending on the risk of recurrence. And this was a pretty extensive study that included 1,500 patients with different kind of glomerulonephritis, and the greatest incidence for allograft loss occurred again with a patient with MPGN and followed by the patient with FSGS. Infectious evaluation, we need to treat every infection. We need to treat for latent TB at the time of candidacy and start a treatment prior to or immediately following kidney transplantation. All patients will be screened for HIV, HBV, HCV, and for CMV, EBV. And we need to treat and screen for strongyloiditis and syphilis. HIV patients are not anymore a contraindication for transplant, and they need to be completely controlled with an undetected viral load, and we can proceed with transplant. For cancer, we have to follow the local guidelines for the general population, chest imaging for all candidate, mammogram, or age-appropriate and sex-appropriate screening, and low-dose CT chest annually for men and women with a history of tobacco smoking, colonoscopy at age 45, especially with patients with inflammatory bowel disease or family history of colon cancer. And for patients with increased risk for renal cell carcinoma, family history for renal cancer, and also should be screening by imaging. And again, for some cancer, there is no need for waiting time after they have been treated, like for the prostate cancer. And we need to be in touch with our oncourology colleagues to be able to calculate or estimate the free survival time for the patient after treatment. Most of our patients will receive oncology clearance after they have reached a complete remission. So a couple of slides to talk about hematology. We need to screen patient for risk for thrombophilia and send for a procoagulation testing. Evaluate patient with significant cytopenias because there's a risk of worsening this cytopenia. One patient are on immunosuppression medication, especially if they are induced with thymo and if they are kept on antimetabolite. We will avoid transplanting patients with leukemia or lymphoma until they have received the curative treatment and achieved remission. For the pulmonary system, patient will have, as I said, a CT for current or former heavy tobacco users per general population guidelines. PFT, again, is also assessed in this patient, and patient with severe irreversible obstructive restrictive lung disease may be a good candidate for dual organ. We'll screen per general population again for colon cancer and for severe GI symptoms, because again, those patients will be long-term on mycophenolate with known GI side effects. Diabetic patients will be assessed and screened for gastroparesis syndrome and symptoms. And then a patient who has history of Hep C need to be treated and complete the treatment and need to receive the immunization for Hep B. We also proceed with psychological and psychiatric assessment, and we refer our patient to a psychiatric and social worker clinic, and especially to take care of any substance use disorder issue and evaluate patient for risk for non-adherence to the treatment. So again, a couple of words for special population. HIV is no longer an absolute contraindication as long as the infection is well controlled, and that we review the drug-drug interaction with the antiretroviral treatment and immunosuppression. And elderly patients are not a contraindication as long as they have a good functional status and they are assessed for any other risk factor. And immunological assessment, I think you had this lecture with Dr. Young this morning. So all patients will be assessed with an HLA antibody screen before the transplant. So I will conclude with the take-home messages. Transplant has a clear survival benefit in kidney patient compared to patients who remain on dialysis or on the waiting list. We need to have a clear survival benefit in preemptive transplantation, and we need to evaluate patient for a risk factor that could represent either an absolute contraindication or a relative contraindication that could be addressed by the appropriate treatment and management. Thank you.